Welcome to the Rad Onc Smart Review GI Cancer Series.
Glad to be here.
Today, we're embarking on what I think is a really crucial and, frankly, fascinating journey through one of the most challenging diseases we face in oncology, pancreatic cancer.
Absolutely. It's a tough one.
Specifically, we're going to dive deep into the evolution of its adjuvant therapy. That's the treatment patients get after surgery, trying to prevent recurrence.
The post-op setting.
It's a field that's seen incredible shifts, some really passionate debates, and ultimately breakthroughs that are genuinely improving lives now.
That's true. There has been real progress.
We'll be tracing what many of us experienced as the great RT debate, the radiation therapy debate, and then watching the impressive rise of modern chemotherapy.
Indeed. Pancreatic cancer, as we're all unfortunately acutely aware, carries one of the most sobering prognoses in oncology. It's just tough.
It really is.
And while we've made advancements, for the vast majority of patients, sadly, the disease is diagnosed when it's already advanced, unresectable.
Yeah, the late diagnosis is a huge problem.
So for that small, crucial fraction of patients who do present with resectable disease, and look, this is already a highly selected group, maybe 15–20% of all diagnoses surgery is their only real shot at a cure.
The only curative modality we have up front.
But, and this is the kicker, even after what seems like a successful curative intent resection, the risk of the cancer coming back, well, it's exceptionally high, both locally, in the surgical bed, and even more commonly, systemically, popping up as distant metastases.
So surgery alone often isn't enough.
Exactly. This stark reality means that effective adjuvant therapy, the whole plan we put together after that surgery, it isn't just like an optional add-on. It's absolutely critical. It's designed to maximize their chances for long-term survival and hopefully cure.
And that perfectly sets up our mission for this session. We're going to trace this often complex, sometimes really contentious evolution of adjuvant therapy for resected pancreatic cancer.
It's quite a story.
We'll dissect the landmark trials that both, built up the role of adjuvant radiation and then arguably cast this long shadow over it, leading to widespread controversy.
Yeah, the ESPAC trial definitely did that.
And then we'll pivot to follow the really impressive rise of modern systemic chemotherapy, moving from single agents, which were okay, to these powerhouse regimens that are finally truly moving the survival needle for our patients, in ways we really only dreamed of a decade or two ago.
It's a bit of a dramatic shift.
To really understand where we are today, clinically, how we make decisions, it's absolutely essential to appreciate this rich, sometimes messy, historical context.
Couldn't agree more. To grasp our current approach, you first have to understand the foundational questions. The very first, most fundamental question researchers had was simple. Does any kind of adjuvant therapy actually help after a pancreatic resection? Or are we just, watching the inevitable happen?
Right. Is doing something better than doing nothing? And for that crucial first answer, we have to go way back to the GITSG 9173 trial.
Ah, yes. GITSG 9173. A classic.
It was a groundbreaking moment, really. The first major trial that unequivocally showed a survival benefit for any adjuvant therapy after pancreatic cancer resection. It wasn't just incremental, it was foundational evidence. It validated the whole concept.
Published way back in the 1980s, GITSG 9173 was, a relatively small trial by today's standards. Only 49 patients enrolled, I think.
Something like that, yeah, really small.
But its impact was massive, totally outsized compared to its size. It randomized patients to either surgery alone, which was standard care back then for resectable disease, versus surgery followed by a very specific regimen. Split-course chemoradiation.
Split course, right. Can you remind us what that involved?
Sure. It was 40 gray of radiation, but delivered in 2 courses, split by a 2-week break. And they gave 5-FU chemotherapy concurrently as a sensitizer during the radiation, and then followed that up with more 5-FU as maintenance chemo.
And the techniques back then were pretty different, weren't they?
Oh, absolutely. Radiation techniques were much more rudimentary. Think 2D planning, maybe early 3D, often using much larger fields than we'd use today. The split-course approach was probably partly to manage acute toxicity, giving patients a break.
Makes sense.
The fact that even with those less precise methods, they still showed a benefit, it really speaks to the potential of targeting that tumor bed, even back then.
And despite the small size, the older techniques, the results were, dramatic. Revolutionary for the time, really.
They were.
The median overall survival was nearly doubled. It went from 11 months in the surgery alone arm to a remarkable 20 months in the chemoradiation arm.
Yeah, almost doubling survival.
Think about that, doubling median survival for a disease that was, and often still is, considered so aggressive, so unforgiving. This wasn't just a statistical blip. It was the first real proof, a beacon of hope, that maybe adjuvant therapy could break that grim prognosis.
Absolutely. It validated the whole concept of doing something post-operatively in a disease often seen as almost untreatable after surgery.
So for a very long time, for decades really, this GITSG trial was the core foundational evidence supporting postoperative radiation in pancreatic cancer.
It was. It established the principle that adjuvant therapy wasn't just helpful, but potentially life-changing. It put chemoradiation on the map as a critical part of the treatment algorithm. The message was clear. Doing something was better than nothing.
Okay, so GITSG set the stage, gave us that initial hope and rationale. But then, as we moved into the 1990s and early 2000s, things got complicated. A wave of controversy started clouding the role of radiation.
The great RT debate era.
Exactly. It cast this long shadow over our field for a generation, and it profoundly influenced clinical practice differently in different parts of the world.
It really did.
At the heart of this controversy are two really pivotal trials, and we need to unpack them carefully. The first one is ESPAC-1.
ESPAC-1. Infamous is probably the right word.
Yeah, published in 2004, arguably the most infamous trial in pancreatic radiation oncology, precisely because of the controversy it ignited and the huge shift in practice it caused, especially in Europe.
It gained that reputation, largely because of its design, which was unique and ultimately pretty flawed.
How so?
Well, it was intended as this sophisticated 2x2 factorial trial. The goal was to compare 4 arms: chemo alone, chemoradiation alone, both chemo and chemoradiation sequentially, or neither, just observation.
Sounds ambitious.
It was, but it was fraught with significant design flaws right from the start. These really complicated how you could interpret the results. For instance, the randomization was complex. Clinicians could actually choose to randomize patients to just the chemo question, or just the RT question, or the full 2x2.
Oh, wow. That introduces selection bias right there.
Big time. Made it incredibly hard to compare the arms cleanly. And on top of that, and this is critical for us in radiation oncology, there was no centralized radiation therapy quality assurance.
No central review of the RT plans.
Nope. Which means the quality, the consistency of the radiation delivery across all the different centers participating could vary significantly. You had heterogeneous radiation being delivered.
That's a major issue.
Huge. And maybe the most striking thing, a full third of the patients who were randomized to the no radiation arms actually end up getting radiation off protocol anyway.
A third. Wow. So the comparison groups were totally contaminated.
Exactly. These protocol violations made the data incredibly messy, maybe even impossible to interpret cleanly. How can you evaluate a treatment when so many patients didn't even stick to their assigned arm?
So with all those flaws, what did the results actually show? Or appear to show?
Well, the results that came out were, frankly, shocking. Adjuvant chemotherapy did show a survival benefit, which was good news, confirmed that chemo helps.
Okay, that makes sense.
But the chemoradiation arm, unbelievably, it looked like it was actively harmful. It actually worsened overall survival compared to just observation alone.
Harmful. How bad was it?
The 5-year overall survival in the chemoradiation arm was a dismal 10%, compared to 20% without it in the observation group. So it looks like chemoradiation cut the 5-year survival in half.
Whoa. Okay, I can see why that caused alarm and confusion.
It was a devastating blow, created immense skepticism about radiation. Despite its significant methodological flaws, which many people recognized, ESPAC-1 had this massive, immediate impact globally.
So people just stopped using adjuvant RT.
In many places, yeah. It effectively killed off enthusiasm for upfront adjuvant radiation in many parts of the world, particularly across Europe, for a long time. It created this powerful perception that radiation wasn't just ineffective, but maybe detrimental, actively harming patients.
Even though the trial itself was questionable.
Right. It fed into this growing skepticism about radiation's role, especially as we understood pancreatic cancer was so systemically aggressive. And critically, it led to this big divergence in practice between continents. Many European centers largely abandoned adjuvant RT for years. That debate still kind of echoes today.
Okay, so that's the infamous ESPAC-1. Now, coming right on its heels, we had RTOG 9704, a major U.S. trial. And this one, you hear people talk about it, but I think it's truly one of the most misinterpreted trials in our field.
I completely agree. It's absolutely critical that residents understand why the misinterpretation happened and what the real takeaways are.
So what was its purpose?
Its true purpose often gets missed. RTOG 9704 was fundamentally a chemotherapy trial. It wasn't an RT trial designed to prove or disprove radiation's efficacy.
Wait, say that again? A chemo trial? But everyone got RT right.
Exactly. All patients in the study, regardless of which arm they were randomized to, received postoperative chemoradiation. Specifically, 50.4 gray delivered with concurrent 5-FU. That was the backbone.
Okay, so what was the randomization testing?
The central question was about the systemic agent used with and after that radiation backbone. Was infusional 5-FU better? Or was the then new drug, gemcitabine, superior? It was trying to find a better systemic partner for an already established local therapy approach.
Ah, okay. So comparing chemo A versus chemo B, both given with standard RT.
Precisely.
And what did it find regarding the chemo?
It showed a trend, an exciting trend at the time, towards improved survival with gemcitabine. Median overall survival was about 20.5 months in the gemcitabine arm versus 17 months in the 5-FU arm.
So about a 3.5-month improvement.
Right. And this benefit seemed particularly pronounced in patients with pancreatic head tumors. This finding led to gemcitabine becoming the preferred systemic agent for many years when given in the context of chemoradiation.
Okay, but then how did it get misinterpreted as evidence against radiation?
Here's the crucial context that often gets missed or ignored. Critics would frequently point to those modest survival numbers, especially that 20.5 months with gemcitabine, and say, see, radiation doesn't work in pancreatic cancer. They'd compare it unfavorably to contemporary chemo-only trials, like TICONCO 001, which we'll talk about.
When? Because Kianico was showing similar numbers with chemo alone.
Exactly. But what they failed to adequately acknowledge was the patient population in RTG 9704. These patients were a much higher risk group than those typically enrolled in those chemo-only trials.
High risk? How so?
For instance, 35% of patients in RTOG 9704 had positive margins in R1 resection. Compare that to just 19% in Kianko 001. That's a huge difference in risk profile.
Okay, so a tougher group of patients to treat in 9704.
Much tougher. Inherently more prone to both local and distant recurrence. So despite treating this significantly higher risk population, RTOG 97004 still achieved a median survival nearly identical to those chemo-only trials of the era.
Which actually suggests the chemoradiation was doing something, right? Controlling the local disease in a tougher group.
That's exactly the interpretation.
Oh.
It strongly suggested the chemoradiation was effectively managing the local regional risk in a patient group that desperately needed it.
And then there's the quality aspect too, wasn't there?
Yes. This is where it gets really interesting, and it provides such a powerful lesson for us as radiation oncologists. A meticulous sub-analysis of RTOG 9704 showed something profound.
What was that?
Patients whose radiation plans adhered strictly to the protocol, meaning they got high-quality, on-target radiation, had significantly better survival.
So the quality of the RT mattered immensely.
Immensely. It powerfully implied that it wasn't just whether you gave radiation, but how well you gave it. Think of it like building a house best blueprint doesn't help if the builders cut corners.
Right. If the radiation wasn't delivered precisely, missed the target, hit too much normal tissue,
Its potential benefit gets undermined. This analysis specifically linked deviations, like geographic miss of the target volume or excessive dose, to critical organs like bowel or kidney, to worse outcomes.
so it underscored the need for meticulous technique.
Absolutely. Careful contouring, patient setup, managing motion, even with limited tools back then, rigorous QA. It's a lesson we carry forward into modern IMRT and SBRT. It highlighted that the issue wasn't necessarily radiation itself, but maybe how it was sometimes delivered, especially without strict QA like in ESPAC-1.
So putting it all together, while ESPAC-1 created this strong anti-RT sentiment, a closer, more nuanced look at RTOG 9704 actually suggests high-quality chemoradiation is an effective tool, especially for those higher-risk post-resection patients.
Precisely. It wasn't a definitive failure of radiation, but rather a demonstration of its potential when done correctly and judiciously on the right patients. It provided a crucial counter-narrative to the prevailing anti-RT feeling stemming from ESPAC-1.
Okay, so while the radiation oncology world was locked in this intense debate, grappling with ESPAC-1 and reinterpreting 9704, the chemotherapy world was sort of in parallel, making steady and really significant progress.
That's exactly right. The systemic therapy landscape was quietly but dramatically evolving, driven by this growing understanding that even if you get great local control with surgery and maybe RT, distant Mets were the ultimate enemy in pancreatic cancer.
Because that's what most patients were succumbing to.
Exactly. The first major step forward systemically came with the KENCOO-001 trial out of Germany.
KENCOO-001, right. What did that show?
This trial was instrumental because it firmly established adjuvant gemcitabine as a new standard of care, moving beyond just watching patients after surgery. It showed a clear improvement in median disease-free survival, pushed it from 7 months with observation to 13 months with gemcitabine.
This is a 6-month improvement in DFS. That's meaningful.
It was a crucial step forward. It gave us a systemic foundation, a chemo backbone to build on. Gemcitabine alone was generally well tolerated, but its impact on overall survival was, modest, often in the low 20-month range. Left a lot of room for improvement.
So better than nothing, but not a home run.
Right. Then, building on that, we saw ESPAC-4, published in 2017. This one pushed the envelope by showing that a doublet, 2 chemo drugs together, specifically gemcitabine and capecitabine, often called GemCap.
GemCap, yeah, we use that sometimes.
That GemCap was superior to gemcitabine alone. This pushed the median overall survival further, reaching 28 months.
Okay, 28 months, that's another decent step up from the low 20s with gemcitabine alone.
It was a significant improvement at the time, showed that combining agents could yield better outcomes. Patients tolerated GemCap reasonably well, though maybe more hand-foot syndrome, more GI toxicity than Gem alone. But it proved more intensive chemo was feasible and beneficial.
So we went from nothing to single-agent Gem to GemCap doublet, making progress.
Steady progress. But the real transformative breakthrough, the true game changer that just reset our expectations entirely for adjuvant therapy, arrived in 2018.
This must be Protégé 24.
You got it. The French Protégé 24 trial. This was the moment the systemic therapy paradigm fundamentally shifted, and we saw what was truly possible.
Tell us about the design. It took resected patients, right?
Yes, took a high-risk resected patient population, patients who had undergone either an R0 resection, clear margins, or, importantly, also included R1 resections, those microscopic positive margins.
So it included some higher-risk folks margin-wise.
Right, and these patients were then randomized to either the existing standard, which was adjuvant gemcitabine, versus this intensified, more aggressive multi-agent chemo regimen, modified FOLFIRINOX.
Modified FOLFIRINOX. Can you quickly explain what that is?
Sure. Modified FOLFIRINOX, or mFOLFIRINOX, is a slightly less toxic version of the original FOLFIRINOX regimen used in metastatic disease. They typically reduce the bolus 5-FU dose and omit the 5-FU infusional pump for home use, making it more manageable for patients in the adjuvant setting while keeping most of its punch. It's still a complex regimen, though oxaliplatin, irinotecan, and leucovorin modulated fluorouracil.
So a 3-drug combo essentially made a bit more tolerable.
Exactly. And the results?
Holy.
Well, they were truly stunning.
How sad.
They didn't just improve outcomes. They completely reset our expectations. The median overall survival in the modified FOLFIRINOX arm was an unprecedented 54.4 months.
54.4 months. Wow. Compared to what in the gemcitabine arm?
Just 35 months with gemcitabine. That's nearly a 2-year difference in median survival. In a disease where every month gained feels like a huge victory.
Almost 2 years longer median survival. That's incredible. What about 5-year survival?
Also dramatically improved.
Yeah.
Jumped from 31% with gemcitabine to 43% with modified FOLFIRINOX.
Wow.
For oncologists and patients, seeing a median overall survival over 54 months was almost unfathomable just years before.
Yeah.
This wasn't incremental progress. It was a fundamental shift.
Yeah, that's a massive leap.
It demanded we reevaluate patient fitness for these intense regimens because the potential benefit was just so profound. Now, the toxicities of modified FOLFIRINOX are, of course, more significant than gemcitabine. Neutropenia, neuropathy, GI issues, requires careful patient selection, good supportive care.
Sure, it's tougher chemo.
But that survival benefit made it crystal clear. For fit patients, this was the new gold standard, no question.
Absolutely. Protégé 24 definitively established adjuvant modified FOLFIRINOX as the new, undisputed standard of care for medically fit patients after resection. It became the benchmark. Everything else is now measured against it. It really hammered home that systemic disease control is paramount.
So with all that history, the RT debate, the rise of chemo, where does that leave us today? How do we actually manage these patients in clinic?
Right, the practical application. The current ASCO guidelines actually provide a very clear, pragmatic framework now. It offers a pretty streamlined approach based on all this evidence.
And that framework starts with a very clear step 1, right?
Exactly. Step 1 is chemotherapy first. For virtually all patients with resected pancreatic cancer who did not get any preoperative or neoadjuvant therapy, the standard primary recommendation is to offer a full 6 months of adjuvant systemic chemotherapy.
6 months of chemo. That's the bedrock now.
It is. The goal here is hitting that microscopic systemic disease that we just know is almost certainly lurking, even after a seemingly perfect surgery.
And the specific chemo regimen really matters here.
Absolutely. For patients who are medically fit, good performance status, can tolerate it, it should unquestionably be modified FOLFIRINOX, based on Prodigy 24's superior efficacy.
Those are the patients who can handle the increased toxicity profile for that huge survival benefit.
Right. But what about patients who aren't quite fit enough for M-FOLFIRINOX, maybe older, more comorbidities?
For those less fit patients, alternatives like GemCap, that gemcitabine and capecitabine combo, or even gemcitabine plus nab-paclitaxel, are acceptable alternatives.
Okay, so there are options for the less robust patients too.
Yes, and while they're less effective than modified FOLFIRINOX, they still offer significant benefit over observation or just gemcitabine alone. The key is getting the most potent systemic therapy you can into the patient first, as quickly and safely as possible, to fight that overwhelming risk of distant mets.
Okay, so chemo first, ideally M-FOLFIRINOX for 6 months. Then what? What about radiation? That's step 2, right?
Right. Step 2 clarifies radiation's role in this modern chemo-first era.
Huh?
And the ASCO guidelines are quite explicit. Adjuvant chemoradiation is not routinely recommended for all patients anymore. Not like in the old GITSG days.
Not for everyone.
No. However, it may be offered to a select, very specific group of patients, those who have particular high-risk features that suggest a greater chance of local regional recurrence.
And crucially, when is it offered?
This is a critical point about timing.
Yeah.
It's offered only after they have completed their full course of systemic chemotherapy.
Ah, so it's consolidative. It's not upfront anymore.
Exactly. It's a consolidated strategy, not an initial one.
Yeah.
The high-risk features that prompt this consideration are primarily an R1 resection, those microscopically positive margins.
Okay, R1 margin, what else?
Or node-positive disease, specifically in the setting of what's deemed an incomplete D1 lymphadenectomy.
Can you clarify incomplete D1?
Sure. A D1 lymphadenectomy is the removal of the immediate parapancreatic lymph nodes, the first draining basin. If the surgeon feels, or the path report suggests, that this node dissection wasn't fully comprehensive for the tumor location, maybe not enough nodes removed, or nodes near the margin couldn't be cleared, that's considered incomplete, it signals potentially involved regional nodes might have been left behind.
So microscopic disease potentially left in the nodes or at the margin?
Precisely. These are patients where we're particularly worried about residual local disease that the systemic chemo might not fully eradicate. Radiation is perfectly suited to try and sterilize those specific high-risk areas.
So this modern paradigm really frames adjuvant radiation as this targeted consolidative therapy, a mop-up operation almost.
That's a good way to put it. A mop-up for potential microscopic local disease, but only for that highly select group with those specific high-risk features, and only after they've finished their critical systemic therapy. It's no longer universal. It's precise and tailored.
Okay, that makes sense. Maybe a quick way to remember those high-risk features for consolidative RT.
Yeah, I like using the mnemonic RNI. RNI stands for R1 resection node-positive disease, especially with an incomplete D1. Those are the RNI patients who might benefit from that extra focused radiation after their chemo.
RNI, R1, node-positive, incomplete, D1. Got it. Understanding that sequence and rationale is really key for clinical decisions now.
Absolutely.
All right, let's shift gears slightly. Let's distill some of the absolute key takeaways from all this into some clinical pearls. These are the high-yield facts, the must-knows for practice.
Sounds good. Pearl number 1. The small, old GITSG 9173 trial, despite its limitations, was revolutionary. It dramatically changed the landscape by showing the first survival benefit for any adjuvant therapy in pancreatic cancer, laying the groundwork for post-op treatment, primarily chemoradiation back then.
Pearl number 2, and this is crucial for residents to get right. RTOG 9704 was fundamentally a chemotherapy trial, comparing gemcitabine to 5-FU alongside RT. It was not an RT trial testing radiation itself. Its results, viewed correctly, actually support using high-quality chemoradiation in higher-risk patients. Don't fall for the misinterpretation.
Exactly. Pearl number 3 focuses on the big breakthrough. The Prodigy 24 trial using modified FOLFIRINOX achieved that unprecedented median overall survival of 54.4 months. Stunning result. It established M-FOLFIRINOX as the benchmark, the standard of care for medically fit patients with resected pancreatic cancer. That's the number to beat.
And our final pearl, bringing it all together for today's practice. Modern ASCO guidelines clearly prioritize a chemo-first approach. 6 months of systemic chemo for all resected patients who didn't get neoadjuvant. Consolidative RT is then considered only for specific high-risk features, remember RNI. R1, node positive with incomplete D1 and only after the full systemic therapy course is done. Sequence is critical.
Chemo first, RT is selective consolidation. That's the modern paradigm.
All right, time to put this knowledge to the test with a quick board blitz. I'll present a case or question, pause a moment for you thinking at home, then we'll break down the answer. Ready?
Let's do it. Application time.
Okay, case 1. A 58-year-old, otherwise healthy man undergoes a Whipple procedure for pancreatic head adenocarcinoma. Final path. T2N1, 3 out of 18 nodes positive, margins are negative, R0. He has a good performance status. What is the most effective adjuvant chemotherapy regimen for this patient? Is it A, FOL, FEL-LSX, B, gemcitabine and capecitabine gemcap, C, gemcitabine and nab-paclitaxel, or D, modified FEL-FOLFIRINOX?
Okay. Thinking about this. Healthy, good, PS, node positive, but R0 resection. The best answer here, no question, is D, modified FOLFIRINOX.
D.
Because this patient is described as otherwise healthy with good performance status. That makes him an ideal candidate for the most aggressive and effective regimen we have, based on Prodigy 24. That trial established FOLFIRINOX as the most effective adjuvant regimen, showing that huge 54.4-month median survival compared to 35 months for gemcitabine. Given his fitness and resected disease, FOLFIRINOX offers the best shot at long-term survival.
And the other options?
Options B and C, gemcap or gemnopaclitaxel, are acceptable alternatives for less fit patients, but they're simply less effective than FOLFIRINOX. In option A, FOLFOX, that's a standard for colorectal cancer, not adjuvant pancreatic. This question really tests if you know the Prodigy 24 data and its implications.
Perfect breakdown. Okay, case 2, back to trial interpretation. In the RTOG 9704 adjuvant pancreatic cancer trial, what was the approximate percentage of patients whose first site of relapse was distant? Was it A, 36%, B, 52%, C, 73%, or D, 94%?
RTOG 9704, first site of relapse. Despite chemoradiation for everyone, the correct answer is C, 73%.
73% relapse distantly first. Why is that such a key finding?
It's a critical finding because it deeply influenced our understanding and drove that shift towards prioritizing systemic therapy. Remember, all patients in 9704 got postoperative chemoradiation, which actually provided pretty good local control. But despite that, the overwhelming majority, about 3/4, still experienced systemic relapse as their first failure.
So the local therapy worked reasonably well, but the systemic disease was the bigger problem.
Exactly. It powerfully highlighted the critical, overwhelming need for better systemic therapy. It told us that while local control was achievable, the main battle was systemic, likely driven by micromets already present at surgery. This data strongly supported the focus shift we've seen, leading to regimens like FOLFIRINOX.
Makes perfect sense. Okay, final case. Case 3, focusing on modern decision-making. A 65-year-old woman undergoes a Whipple. Final path. T3N1 tumor with a microscopically positive retroperitoneal margin, so R1 resection. She has a good performance status. What is the most appropriate sequence of adjuvant therapy for her? Is it A, upfront chemoradiation to 50.4 gray, then chemo? B, 6 months of adjuvant chemo with FOLFIRINOX, then consider consolidative chemoradiation? C, adjuvant radiation alone to the tumor bed? Or D, observation, because R1 resection has a poor prognosis anyway?
Right, 65, good PS, T3N1, but R1 margin. Applying the current guidelines. The best and most appropriate answer is B.
Explain why B is the correct sequence.
B follows the modern ASCO guideline paradigm perfectly. It integrates the chemo-first approach with the selective use of consolidative RT for high-risk features. Step 1, deliver the most effective systemic therapy. She has good PS, so that's 6 months of modified FOLFIRINOX to hit the micrometastatic disease. Step 2, she has a significant high-risk feature, that R1 resection. So after completing the systemic chemo, it's absolutely appropriate to then consider and discuss consolidative chemoradiation to the tumor bed to improve local control, targeting that positive margin risk.
And why are the other options wrong?
Option A, upfront chemoradiation, is outdated. It delays crucial systemic therapy. Option C, radiation alone, is insufficient, ignores the dominant systemic threat. And option D, observation, is definitely not acceptable. While R1 is higher risk, modern adjuvant therapy offers a significant chance for control and improved survival. Nihilism isn't warranted. B represents the standard evidence-based sequence.
Excellent. That really illustrates the modern algorithm. Now let's just briefly touch on the core controversies and advances that have really shaped this field. It feels like it centers on that great RT debate versus the rise of systemic therapy.
It really does. That RT debate was significant, impacting practice for years. It largely came from those conflicting interpretations. ESPAC 1, flawed as it was, creating this strong negative perception of upfront RT due to its misleading results.
Suggesting harm, yeah.
Contrasted with the more nuanced understanding of RTOG 9704, which, when you dig into the high-risk population and the RT quality data, actually supported high-quality chemoradiation for select patients. This historical tension, local versus systemic, how to sequence them, it defined an era, forced us to scrutinize data more carefully.
But the advances side of this is the more exciting story, isn't it? The rise of systemic chemo.
Oh, absolutely. That's the truly uplifting part. The meteoric rise of systemic chemotherapy. It wasn't one sudden leap, but that progression. Single-agent GEM, then doublets like GemCap, culminating in that incredible survival benefit with modified FOLFIRINOX and Prodigy 24.
That trial really changed everything.
Didn't just improve outcomes, it dramatically shifted the entire treatment paradigm, moved us decisively from an era where local therapy was often a primary or early focus to a chemo-first approach. Prioritizing systemic control, acknowledging micrometastatic disease is the main driver of failure.
And the ability to offer patients a median survival over 4 years.
Monumental. It remains a huge achievement in this tough disease. And it forced us, as radiation oncologists, to really reevaluate our role, moving from potentially upfront to much more targeted, consolidated, in specific high-risk scenarios after chemo.
So wrapping up today's discussion, we've really unraveled this complex, often controversial history of adjuvant therapy for resected pancreatic cancer. It's been quite a journey.
A dynamic evolution, definitely. Driven by trials, biology, understanding failure patterns.
We've seen how the paradigm shifted so dramatically. From a strong focus on local therapy, or at least considering it up front, to this definitive chemo-first approach pushed by powerful new systemic regimens.
It doesn't mean radiation has zero role, but its role is now much more precise, more targeted, and crucially follows systemic therapy.
Right. Adjuvant RT's role, established by GHG, complicated by ESPAC 1, is now selective. Targeted consolidation for those high-risk RNI patients after chemo lays the groundwork.
Meanwhile, adjuvant chemo saw that meteoric rise, culminating in Prodigy 24, establishing modified FOLFIRINOX and its remarkable 54.4-month median survival as the benchmark for fit patients. Truly changed the game, offered unprecedented hope.
The current paradigm for resected pancreatic cancer, then, is abundantly clear. For most patients, aggressive systemic chemotherapy is king. The journey's been profound.
Absolutely. But this whole conversation about what happens after surgery sets the stage perfectly for our next session, Pancreas Part 2. We'll explore the neoadjuvant revolution, what happens before surgery, and how that changes the game even further.
Looking forward to that. You can find detailed show notes and practice oral boards at radoncSmartLearn.com. And be sure to subscribe to Rad Onc Smart Review for our next episode.
Thanks for tuning in.